My name's Naveen Cavale. I'm a plastic surgeon that works here at the Cadogan Clinic. I'm also a consultant in the NHS at King's. Been a consultant since 2009, doing reconstructive work there, aesthetic cosmetic work here at Cadogan for the last 3 years or so. Here at Cadogan, I specialise mainly in breast surgery, and then sort of going above rhinoplasty is my next popular procedure, and then other facial procedures. So breast reduction is primarily an operation to reduce the size of the breasts, to make them smaller. As well as that, you're also repositioning the nipples so that they are more forward pointing, because that's one of the issues with breasts that are quite big. They tend to have drooped, and therefore things tend to point downwards. They also tend to have lost some fullness in the upper part of the breast, the upper pole. And so a breast reduction not only makes the breasts smaller, it also lifts them up to give you a bit more fullness in the upper pole. To know if you're a good candidate for a breast reduction procedure, first of all, you've got to be fit overall and pass the tests that the anaesthetist will need you to get through, because this is an operation done with you fully asleep under a general anaesthetic. You need to be of a suitable weight, and we tend to specify a body mass index of 28 or below, thereabouts, because we know that you can get more problems with recovery and healing after surgery if your BMI is higher than that. You need to basically want to go through this procedure, because it isn't without its costs. So you need to understand what the procedure actually involves, the scarring involved, the downtime involved, and some of the other potential risks. So a breast reduction procedure itself isn't probably one that you'd want to watch, as an average person. It's not necessarily the most pleasant thing to see there, and it can be quite shocking. So I won't go into too much detail, but what it essentially is if you were to think of the breast as being a pudding, with a cherry on top, it's almost taking a slice of the pudding out and then closing it together to make it a smaller pudding. There's also a slight added complication that we have to keep in mind, is that the cherry on top of the pudding, which is the nipple, has to be connected to a blood supply, which is the plate that the pudding sits on. And so therefore you have to keep a stalk attached from the plate to the cherry, as it were, whilst you're doing this, which is what's called the blood supply or the pedicle to the nipple. So we're effectively kind of taking a wedge out of the breast, bringing it together to make a smaller breast. It's slightly more complicated than that, but I won't go into those finer details. But the end result is things get pulled together, tightened, and lifted up. A breast reduction itself is an operation, put simply, where if you were to think of the breast as being like a pudding with a cherry on top, we're taking a slice out of it and then folding it together to make a smaller pudding. The cherry on top, though, which is the nipple, has to remain attached to its blood supply, which comes from the plate underneath. So you have to keep a stalk attached, and that's the careful part of a breast reduction. So effectively what you're doing is taking a wedge out, keeping this attachment from bottom to top, folding it together, and making a smaller breast. So women who request a breast reduction typically are not only complaining about the size of their breasts being too big and all of the problems that entails with not being able to find clothing that fits, not feeling confident wearing tighter clothing. They also get problems because of the weight, so shoulder pain, bra strap pain, neck pain, back pain, are all typical things that people talk about. The actual weight, it's like carrying a rucksack on your front, 24/7. So as a result, turning over in bed is difficult. Hugging people can be uncomfortable because of having this extra bulk in front of you. Running, exercising, swimming is difficult because breasts are quite a large part made up of fat, so therefore they act almost as flotation devices. So quite often you will get women coming along going, I just wish my breasts could be smaller so I can then get on and do some exercise and then get back into shape overall. A good candidate for a breast reduction is probably also someone who has excess in the breasts only, as it were, and not necessarily in the rest of their body. So if there is tissue going further around towards the back, that can make things more difficult. So you may not get as neat a shape with just a pure breast reduction. It might be that you also need to reduce your weight overall and then have a breast reduction, and you're much more likely to be happy that way. A typical candidate who is asking for a breast reduction is quite often complaining not only about the size of their breasts being an inconvenience, and the size is an inconvenience because finding clothing to fit is difficult, finding confidence whilst wearing slightly tighter fitting clothing is an issue, and so therefore people tend to hide them by wearing looser clothing. The kind of problems that women also report, apart from just the fact that they've got larger breasts, are the problems that go with the weight of larger breasts. And that's shoulder strap pain from the bras, neck ache, backache, shoulder ache, and getting sores because of bra straps being pulled down. Exercising can be an issue as well because of this extra weight they're having to carry all the time. Swimming can be particularly troublesome because the breasts, which are in a large part made up of fat, can actually act as flotation devices, making swimming difficult. Running can be really uncomfortable because of the weight. And so therefore we do get people coming in saying, if only I could lose the bulk of this weight on my breasts, it would allow me to then exercise more and then get into shape better overall. A breast reduction is always done under general anaesthetic in my practice. It's done as a day case. You arrive about an hour before you're due to start your procedure, having been told when to stop eating and drinking. The actual surgery takes about 2.5, 3 hours of being asleep, and then you tend to go home about 2 hours after waking up. So generally speaking, you're in the hospital for most of the day. You're actually asleep having surgery for about 3 hours of that day, which may not seem like a very long time, but it's a medium length procedure in terms of compared to other plastic surgical operations that I do. After surgery, you will wake up from your general anaesthetic wearing a bra, which is for support. You'll have sticky tape over the incision lines that have been stitched together. It's all dissolving stitches, so there are no stitches to be removed eventually. The sticky tape will go round the nipple, underneath and across typically. That's a full anchor pattern breast reduction. When you wake up, you might be a little bit uncomfortable. Your pec muscles can ache because they do get a bit bruised with this surgery quite often. So moving your arms might be a little bit achy, but it's important to keep them moving, otherwise they can stiffen up. The bra will help a lot with pain relief, and you'll go home wearing that bra, with somebody taking you home and making sure you're okay overnight. So you'll need a partner to help you, look after you for the first night for sure. You'll be able to shower the next day. You take off the bra, but you keep the sticky tape in place and have a shower as normal. Again, probably with somebody just making sure you're okay for the first time. And then after that, you're probably okay to look after yourself independently without doing anything too strenuous. And then you'll come back a week after surgery to see our nurse, who will take the bra off, check everything is okay, take the sticky tape off, make sure the incision lines are healing okay, make sure the nipple is also healing well with a good blood supply. You'll then probably have the dressing replaced again for a few more days, and then it might be that you take it off yourself or you come back for another check after a week for the nurse to help you do that. And then after that, you're pretty much managing things on your own, slowly getting back to normal activity. In terms of getting back to day-to-day activity, that's probably happened within the first week. You'll be able to look after yourself, cook for yourself, simple things, shower yourself, and spend time alone at home. In terms of getting back to work, 10 to 14 days. Getting back to exercise, that might take a little bit longer, especially for upper body exercise, because your arms can hurt. But you might be able to get back to walking and maybe an exercise bike after, say, 3 weeks or so. By 6 weeks, you're doing pretty much all exercises, and by 3 months, it's as if you've not had surgery. You're kind of back to normal. After surgery, you'll wake up in the recovery room with a nurse wearing a bra that we fitted you. Underneath that bra are paper sticky dressings that I typically use, and underneath that are dissolving stitches that don't need to be removed. You'll probably feel a little bit uncomfortable, especially when you move your arms, because your pec muscles can be a little bit bruised and a bit sore, but that tends to get better over a few days. And you'll get taken through to the main ward once you're fully awake, where the nurses there will make sure that you wake up, have something to eat and drink, go to the toilet normally, manage to be steady on your feet before getting taken home by somebody that's going to stay with you at home for the first night. Like all other surgery, breast reduction does have its own specific risks. The main one is to do with the actual nipple itself. You need a good surgeon who's going to ensure that the blood supply is maintained properly, so that the nipple doesn't run into problems later on. The main risks that we talk about with regards to nipple are the sensation, and do be prepared to lose feeling in your nipples. That's fairly common after breast reduction surgery. Also, do be prepared to consider how you'd feel about not being able to breastfeed after reduction surgery. So quite often women who have breast reduction have thought about it for a while, completed their families, and are now ready to not be able to breastfeed if need be. Getting the size exactly right is something that you need to be prepared to tolerate. I never promise that you will be exactly this cup size or exactly that waist size or chest size. It can vary, and again, surgeons will use their discretion to maintain a good shape and hopefully give you the best result possible that balances not only the reduction in size but also the best shape. If breasts are made too small, they can sometimes look an odd shape, so we try and avoid that. So there is a bit of compromise there. There are other general risks that go with anaesthetic, which you'll be aware of from looking at our website elsewhere. Breast augmentation or breast implant operation is an operation to increase the size of the breasts, put simply. Okay, so the idea is to take the breasts that you have now and make them bigger. We can refine that by doing other procedures to change the shape of the breast, and we can do other things to try and improve the position of the breasts if they're different, or the position of the nipples if they're different. A simple breast augmentation using implants is a really straightforward operation, the most commonly performed one worldwide as far as cosmetic surgery is concerned. Breast augmentation involves a small incision underneath the breast to make a pocket that can either be in front of the pec muscle or behind the pec muscle, or a combination of both, the so-called dual plane or muscle split techniques that I like doing. The implant is put into this pocket. The size has been predetermined during your consultation beforehand. Your surgeon can guide you as to what is a suitable size, a suitable measurement of implant, and one that is going to fit your body and look proportionate. A good surgeon won't let you go too big, because not only does it look very unnatural, it could also cause problems later on in life because of the extra weight. The same sort of problems that women with larger breasts come to us asking for reductions for, which we obviously want to avoid. Surgery for a breast augmentation is carried out again under a general anaesthetic with you fully asleep. It takes about an hour to actually do, but you will spend longer time in the hospital before and after surgery. You'll typically wake up with a small incision underneath, around about 3 to 4 centimetres in length, which has been closed with dissolving stitches and covered with a paper sticky tape. You'll wake up wearing a bra. You'll wake up wearing a strap over the top to push the breasts down, which is important for the first few weeks. And you'll go home the same day with somebody looking after you at home for the first night. You'll be able to shower the next day, and you'll come back and be checked by our nurse a week later who'll make sure things are healing up okay. Typically you'll be able to get back to normal activities over the next few weeks. By about 6 weeks you're doing most things, and by 3 months you're doing everything and more. A breast augmentation or a breast enlargement is an operation to make the breasts bigger, put simply. It's an operation carried out under a general anaesthetic with you fully asleep. Involves being in the hospital for the day, so you arrive and go home the same day. You'll be asleep for about an hour during surgery, but you will spend more time before and after your operation in the hospital. You'll wake up having had a small incision under the breasts about 3-4 centimetres across made to form a pocket inside the breast, which can either be in front of the muscle or behind the muscle, or a combination of both, as I like to do with my split muscle technique. You will have the incision closed with dissolving stitches, dressing put over the top of that, and you'll typically wake up with a bra and a strap over the top to push the implants and the breasts down. A good candidate who's ready to have a breast augmentation is someone who's spent a bit of time thinking about it. this should not be an impulse buy, a rushed decision. And typically my patients have already done that. They are very well informed. They've done their research. They've looked people like me up on the internet and looked at websites for more information to learn about the procedure. And they've really decided that this is something that is going to make them feel better. It's not just about having big breasts to compare with the next person along. It's not about trying to satisfy someone else. Typically, good patient for a breast augmentation is doing it for themselves and is going to feel happy once they've had it done for themselves. And by that, what I mean is that by having larger breasts, they are going to feel more confident in themselves. They're going to be able to wear clothing that they feel better in. They're going to be able to look at themselves in the mirror and feel better about themselves. And all the other things that follow tend to be secondary. But generally speaking, somebody who has thought it through and has decided that, by having my breast enhanced a bit or, a certain amount, I'm just going to feel better in myself, in my own body. That's the typical candidate who is a really good candidate for a breast augmentation and who I know is going to be happy after surgery. Someone who I think is not good for a breast augmentation is generally someone that I think is not doing it for the right reasons. If they're not doing it for themselves, if you get the feeling they're doing it for somebody else, to compete with friends, to perhaps please a partner, or to try and revive a relationship or a career that may not be going the way that they want it to. Those are all absolutely the wrong reasons for doing this. The candidates that are happy having the surgery are the ones that tend to be doing it for themselves. Breast augmentation, like all operations, carries its own set of risks that you need to be aware of before you decide to undergo it. And any good hospital, any good surgeon, any good anaesthetist will be doing everything they can to minimize these risks, both in terms of the hospital being well managed, cleanliness, smoothly run, using high quality staff, high quality equipment, high quality implants. In terms of, from my point of view, what do I do to minimize these risks? I'll do everything I can to ensure that you are fully prepared for surgery, that by the time you start your operation, you're at the optimal point of actually now being ready to have surgery and go through it as safely as possible. So what are these risks? Like all surgery, the general anaesthetic carries its own risks, which you need to be aware of, which I won't go into here. But in terms of specific to breast augmentation surgery, there are the typical risks of pain, which actually is not really a risk, it's almost guaranteed. Expect some pain for the first few days, but it does get better. There's a risk of bleeding after surgery, about a 1 in 100 chance that you may need to go back to the operating theatre. I think my numbers are probably better than that looking back over the last few years, but that's the number that I still quote, and that's the typical number that you'll hear. There's about a 1 in 1,000 risk of getting a bad infection. And this is important. If you get an infection in an implant, it may have to be removed in order to get rid of that infection, and then you may have to wait several months before you can have another one put back in again. Then there are the long-term risks with implants. They don't last forever. So do be prepared to have your implants changed in about 15 years' time. This is not going to be your last operation. You may decide to have them removed, or you may decide to have them replaced. And that's typically because of a condition called capsular contracture, which is hardening of the scar tissue around the implant. Capsular contracture is something that happens with all implants eventually. So you need to be prepared for it. And if it does become a problem, you need to be prepared to deal with it. It's where the scar tissue can squeeze the implant, start making things feel harder, feel more painful, potentially uncomfortable, and make things look unusual. And that might be what you end up coming back to have dealt with in 15 or so years' time when you'll need your implants exchanging. If an implant gets a hole in it, what we call a rupture, a bit like a puncture in a tyre, which can happen again with time as they get older, that can go on to cause this hardening, this capsular contracture, and that might be something that brings you back to have implants changed. ALCL is a rare form of cancer that is associated with breast implants, and it's being talked about a lot more now than it has been over the last few years. We're still trying to understand it. We still don't quite get it. We don't quite know what causes it exactly in terms of breast implants being put in, but it seems like there are certain types of implants that were more responsible for producing cases of ALCL. We have stopped using all of those implants now in our practice. They were the very rough coated implants manufactured in a certain way. We're now using either smooth implants or we're using virtually smooth implants manufactured in a slightly different way. ALCL is a form of lymphoma, which is a bit like leukemia. It's a cancer that can be treated if it's caught early enough. Like everything else, it causes symptoms in the breast that you shouldn't ignore. If you were to get a swelling, then you get it checked out like any other lump in the breast, and your surgeon or your doctor will send you to a breast clinic to have this investigated and tests done to see whether or not you have developed this very, very, very rare cancer. It is very, very, very rare. Breast cancer in this country carries a risk of 1 in 8. This cancer carries a risk of 1 in tens of thousands. If you were to have an implant put in, and if you were to be one of the very unlucky people to develop this, generally speaking, by having the implant removed and having the scar tissue around the implant removed, that's usually enough to cure you of this cancer. However, you will be passed on to the right people to treat this if it were to happen. ALCL can be treated if it is caught early enough. Fat transfer is a really exciting new tool that we now have that can add to a breast augmentation. I don't think it necessarily replaces breast implants altogether, but it can do in certain very select cases. But actually, in the main, it's really good for an adjunctive procedure. So in addition to having implants put in, if there's a big gap between the breasts, it can be used to build up that gap and give a better shaped breast. What is fat transfer to the breasts? Well, that's where basically we take fat from another part of the body where you don't want it particularly, using liposuction. But what we do is, instead of discarding it, we process it in a way such that we're now left with the best fat cells, and then inject those in small volumes, bit by bit by bit, very carefully, to build up the area of the breast that we want to, where we want to enhance the shape. And the typical area is the cleavage area, where if implants have been put in and they are sitting apart because of the natural shape of the breasts and the position of the breasts being apart, we can then enhance the cleavage area by adding a bit of fat into the middle to just give you a better inside cleavage décolletage area, just to make the shape that much better. I would say fat transfer is not something that is an overall alternative to implants. There's been a lot of talk of it replacing implants and this is the way forward. I really don't think that's going to happen. I think fat transfer, when it's been done to replace implants, has actually not worked very well, because you need very large volumes of fat. So number one, you need very large volumes of fat to give from other areas, which quite often when we're with not very much breast tissue don't have. Number two, if you were to inject large volumes of fat into the breasts, it can cause problems. Survival of that fat is less. Problems because of what we call fat necrosis and lumps developing can be higher. So personally, I don't like doing fat transfer as a pure alternative to breast implants. I prefer doing it as an adjunct in addition to breast implants. All surgery carries risks. What I would say is that by coming to a place like the Cadogan and having surgery with somebody like myself and with the anaesthetic and nursing team and all the other adjuncts that we have here, those risks will be minimised to the best of our ability. Ear reshaping surgery, or otoplasty or pinoplasty, different names given to it, is effectively an operation in the main to reduce how much the ears tend to stick out, how prominent they are. It's an operation that is done under local anaesthetic or general anaesthetic. I tend to do it more under general anaesthetic in my practice. It's done by correcting two main things. Ears are prominent because of two features in the main. One is that the fold, the anti-helical fold of the ear, is lacking, which makes the ear unfold like that. The second reason is that the whole ear tends to be pulled out and can end up looking more prominent. So surgery to correct prominent ears, or ear reshaping surgery, is designed to correct those two things. Number one, to create the fold in the ear, and number two, to push the whole ear further inwards, closer to the head. The surgery itself is done via an incision, a cut behind the ear, so the resulting scar tends not to be visible even in those people with quite short hair, because the ear tends to have been pushed in and therefore the scar's nicely hidden. We tend to, in the main these days, reshape ears by doing what is called the suture technique, where stitches, permanent stitches, are used to recreate the fold and to bring the ear closer to the head. The stitches to the skin are dissolving, so there's no fiddling around having to have stitches removed a week later. And instead of having a big helmet, crash helmet sized dressing and bandages, I now use a simple headband, a bit like the 1980s tennis players used to wear, that you'll keep on 24 hours for the first week, 10 days, and then you'll wear at night time for the next 6 weeks or so. Liposuction is an operation that is used to remove excess stubborn fat from whichever part of the body you don't want it in. It's usually done using small incisions. It can be done under local anaesthetic or general anaesthetic, depending on how big an area we're talking about. The little incisions are used to introduce a cannula, which is basically a hollow tube with holes at the end that cut the fat away and suck the fat away into a machine. We inject fluid into the area before we suck it out, so there are different types of liposuction depending on how much fluid has been introduced. We can also combine the liposuction with other modalities such as laser or ultrasonic disruption of the fat, or using extra mechanical movements made by the machine to help actually break the fat up. Liposuction is an operation to remove fat using a hollow cannula or a hollow tube, which is connected to a suction machine and has holes at the end of it that help cut the fat away as you move it in and out of the area of fat in the body. It's usually done under a general anaesthetic or a local anaesthetic with you awake or asleep, depending on how large the area is that needs removing. And it can also be combined with other techniques such as laser liposuction or ultrasonic assisted liposuction or mechanical assisted liposuction, which is the method I use. And that's where a machine moves the cannula back and forth very fast, which allows a lot more of the fat to be broken up and removed within a certain time, therefore making things a lot more efficient and a lot more effective. Liposuction is really good for stubborn areas, so it's not a tool to help you lose fat overall. It's not a weight reduction tool. It's not an alternative to diet or exercise weight loss. If you have a stubborn area that you just don't like in spite of your best efforts, you've got some on the side of the hips, or there's just a bit on the belly that remains, or perhaps under the chin in the neck area, stubborn areas that no matter what you do, you just can't get rid of, that's where liposuction is really good for removing those just annoying, hard to get rid of stubborn areas. Rhinoplasty surgery is an operation to reshape the nose. Typically, it's to reduce the bump on the nose and the side profile. That's the most commonly requested feature that people want corrected. It's perhaps to reduce the broadness of the nose from the front view, and it's perhaps to address the shape of the tip of the nose if that's too big. In my practice, I carried out under a general anaesthetic with you fully asleep. It takes about 2 hours to do, but you'll spend most of the time, most of the day in hospital. You'll go home the same day, having had surgery under a general anaesthetic. You will have had a little incision underneath the nose, as well as incisions on the inside of the nose, which is called an open rhinoplasty, which allows me to get to the bone as well as the cartilage, the more mobile part of the nose, and reshape both of those, the bone as well as the cartilage. In terms of reshaping the bone, that's typically done either using traditional bony instruments such as the hammer and the chisel, but we also do have more modern alternatives such as the piezo ultrasonic saw, which is a really nice development which uses high frequency ultrasound to do very precise cuts in the bone, allowing you to reshape things that much more precisely and carefully. It just reduces the unpredictability of using some of the older tools that we have done in the past, whereby controlling the cuts and the breaks in the bone has been a bit difficult to really control. The other advantage of the piezotome is that it only cuts bone. It doesn't damage soft tissue. So a very nice way of thinking of it was if you were to use it to cut an egg, it would cut the shell, but it wouldn't cut the inside membrane of the egg. So you can actually cut eggs really precisely with this tool. There are some demos out there that you might want to Google. Surgery, I think, still very much has a place in aesthetic practice. And I think one of the really good developments recently is that we're no longer saying you must have surgery and that's the only way. And we're actually now working out how we can work alongside the non-surgical modalities out there, how we can work alongside our non-surgical colleagues in really synergistic ways, which I think is a really, really healthy development. It's no longer this either or that as it used to be perhaps in the bad old days. Surgery very much has a role. There are certain things that you just can't do, without having surgery. A breast enlargement is a typical example. There is no way of increasing the size of breasts without undergoing surgery of some sort. All of the non-surgical alternatives that have been tried out there, in my opinion, don't really work in terms of increasing the size. But however, a good non-surgical colleague will be able to advise in terms of tightening up the skin perhaps to maybe improve the shape of the breasts. Similarly, when it comes to the face, rhinoplasty is a good example where non-surgical and surgical can exist side by side and work really well together. Non-surgical rhinoplasty, I think, is really coming of age, and a good non-surgical rhinoplasty doctor will be able to do amazing things without you undergoing a full operation with someone like me. However, there are limits. A rhinoplasty can't make a larger nose smaller. Whatever a non-surgical rhinoplasty does, it will effectively increase the nose, but it is hiding those. It's creating the illusion of a better shaped nose that fits your face better. But there are limits, which is where surgery comes in. And if you do have a bump on your nose that is beyond a certain size, or if you do have a tip that is beyond a certain size, or nostrils that need to be reduced, then I'm afraid surgery is the only way to make that happen. But surgery quite often is the best method for correcting some of these issues. If you have a very big bump on the nose, surgery really is the only way to reduce that down in a meaningful way. If you have a very big tip or very wide nostrils, then I think it really is only surgery that can achieve that. Having said that, don't be put off by surgery because, it's scary or it's, something to be, frightened off by. At Cadogan, we're doing day surgery on almost all of our procedures now, with patients coming in and out on the same day. We are doing them under a general anaesthetic with patients, having things done really very, very safely and going home actually feeling pretty good, and resting up in the comfort of their own beds rather than having to spend, nights in hospital as a patient. I think surgery, cosmetic surgery in the future is going to be performed pretty much in the way that it's been done at the Cadogan for a very long time. It's done under a general anaesthetic using TIVA, total intravenous anaesthesia, which is a really nice, gentle way of having a proper, full general anaesthetic. You're still properly asleep, but it's done very gently. It's a very gentle way to go to sleep, and it's a very gentle way to wake up. In addition, I think the way to have cosmetic procedures these days is to not stay in hospital overnight and not spend night on night kind of being treated like a patient. I think you have the surgery in a hospital safely and you recover in the comfort of your own bed with your own family looking after you, eating your own food and being able to sleep properly without all the noise and the hubbub that goes with big hospitals. And I just think it works so much better. My patients now, having had things done this way, are just so much happier compared to when I used to treat them more like patients and keep them in for much longer. One of the great things of coming to a place like Cadogan Clinic that offers all modalities, surgical, non-surgical alike, is that you're not going to come to one place which is a one-trick pony, as it were. You will get the whole gamut being offered to you, and you will end up having what is the most appropriate treatment offered to you. The other good thing is that in the way that these treatments can be combined will also be optimal. They'll all be knitted together in a really nice way that just works overall, I think, without you just being oversold one type of treatment because that's all that they offer, or being sold just surgery because that's all that they offer. I think if you can come to a place where you know that everything is potentially available for you. If you come and see me, I'm a surgeon, I operate, I don't do non-surgical procedures in the main, but if I think a non-surgical procedure is better for you than surgery, I will tell you that, and I will send you to a good, safe, non-surgical colleague. Why come to me as a surgeon? I will always try and tell you or convince you that I'm the safest of surgeons. I really don't like taking unnecessary risks. Why am I safe? It's because I've been trained properly. I am locally based. I am properly qualified as a plastic surgeon with the FRCS Plast. I'm a member of all the right societies. I'm insured in the UK. And I don't just do cosmetic plastic surgery. I do reconstructive surgery as well in the NHS. I teach other surgeons how to do that as well as cosmetic surgery. And I'm working outside the medical world in the UK as well. Some of the charity work that I do as well keeps things balanced and real, and I just, as a result, think I can offer you sort of a more broader, holistic service as a safe, proper plastic surgeon. I've really enjoyed coming to the Cadogan Clinic. It's a different way of doing things, and I think it has been ahead of its time for quite some time, which I hadn't realised before I came here. Traditionally, patients have come to hospitals and had surgery and then ended up spending a long time in hospital afterwards, going home the next day, having drains put in that need to be removed the next day, and really being treated more like patients as you would probably typically think of in a hospital. Now, Cadogan Clinic is a clinic, but it's also still very much a hospital. You do come in, you do have surgery, you do have a proper anaesthetic, but the thing is, it's just being done in such a safe, gentle, quick, efficient and effective way that as a result, you don't really feel like you've ended up being turned into a patient. You come in, you have your surgery pretty efficiently and you go home. And you have had your surgery in a way whereby your anaesthetic and your recovery has been performed in a very gentle way that you're able to get up and walk out and go home. You've had your surgery performed in an efficient way whereby you don't need to have drains put in, you don't need to end up spending extra time because of all of these extras that actually we're working out were not really necessary in the first place. It just makes things safer, quicker, more efficient, more effective, and just that much nicer. A labiaplasty is a procedure that has started to gain in popularity of late. It's basically a procedure to reduce the sort of prominent parts of the labia, the vulva, that a lot of women find is either uncomfortable or unsightly. There are lots of different ways of doing it, and lots of surgeons will tell you that their method is particularly good for one particular reason or another. We've all got our own preferences, and I wouldn't get too caught up in the different techniques. What I would say is find a surgeon that you're comfortable with. Yeah. Labiaplasty is a procedure that has been increasing in popularity lately. It's basically a procedure to correct what a woman might feel is excessive or uncomfortable tissue in the labia region, the vulva. And it's either done for reasons of comfort or for aesthetic reasons, just to make things look a little bit more acceptable. It's performed either under a general anaesthetic or a local anaesthetic. Either way, it's done as a day case with you coming and going out of hospital on the same day. And generally speaking, it's quick, it's a simple procedure, and it's one that women tend to be very happy with once they've had it done. There are lots of different ways of doing it, there are lots of different ways of doing it. Different surgeons will do their own preferred method, and I wouldn't necessarily get caught up in this method over that that method, and this surgeon over that. Find someone that you're comfortable with, because it is obviously an intimate part of the body that you're having operated on. Find that you are, able to undergo this without any doubts, and find a surgeon that makes you feel comfortable and confident, and generally speaking, you're going to be very happy with the result. Abdominoplasty, or a tummy tuck, is a procedure that is used to remove excess tissue from the belly area. It's typically an operation performed under a general anaesthetic. It is quite often combined with liposuction, particularly to the sides, the flank area. And in the correct, suitable patient, it's an amazing procedure and can be phenomenally effective. It is an operation whereby tissue, skin, and some fat underneath, between the belly button and the hairline lower down, is removed in a sort of crescent shape. You will typically end up with a scar that goes from hip to hip, just going above the hairline. And if it's a full abdominoplasty, it will also entail a scar around the belly button. There's a smaller version called a mini abdominoplasty, or a mini tummy tuck, where the belly button part isn't done. There is skin removed from below the belly button, again in a crescent shape, again leaving you with a longer scar from hip to hip, perhaps a bit shorter with the mini tummy tuck. Again done under local anaesthetic, again maybe combined with liposuction, and again done as a day case. It can be combined with liposuction, but we have to be careful. There are limits to where we can do liposuction. I typically will do liposuction to the flanks, but not to the top of the tummy when I do an abdominoplasty, because I worry about the blood supply to the abdominoplasty skin being compromised. So you may have to come and have that done later on. You'll wake up from your general anaesthetic, having had dissolving stitches put in the main incision line as well as around the belly button. You'll have sticky tape dressings over that area, and you'll wake up wearing what is called a compression garment, either a girdle or a corset type of garment, or even a sort of wrap that is made of elastic and Velcro. These are deliberately put on very tight to try and minimize swelling, to try and increase your comfort after surgery, and to help you therefore get moving that much faster. You will come back to see our nurse after a week to make sure everything is healing up okay, and you'll tend to come back and see me after a few weeks to check that everything has gone okay. You will wear your garments for 6 weeks, typically 24/7. I'm afraid it's not the most pleasant thing to have to go through, which is why sometimes people opt to have this done in the colder months. You may undergo what is called post-liposuction, post-tummy tuck lymphatic massage, which we can arrange for you at the Cadogan Clinic. Generally speaking, it is a relatively straightforward operation. It's a slightly bigger operation compared to a lot of other procedures, but if done properly, done safely, done efficiently in a place like the Cadogan Clinic, you'll get a good result that you're very happy with. A mummy makeover is an operation typically that combines rejuvenation of the breasts with the tummy after having had children. Unfortunately, the typical changes that children do to a mother's body are some shrinking in the breast size, perhaps a bit of droop and loose skin, and similarly with the tummy there can be a little bit of excess skin and droop that you may want to get rid of. So we typically combine these into one procedure in one sitting. As far as the breasts are concerned, it could be a simple, straightforward breast augmentation just to help fill things out and perhaps provide a little bit of a lift, which can be done with implants alone in the right candidate. Or it might be implants combined with an uplift type of procedure, or it might be implants combined with an uplift and perhaps fat transfer to enhance the inner and upper parts of the breasts. The tummy tuck side of things is again combined with the breast procedure at the same sitting, under the same anaesthetic, the same episode in hospital. And it's typically a tummy tuck, either a full or a mini tummy tuck, with or without liposuction to the sides, and perhaps any other areas of the body that we can do safely within the limits of a safe anaesthetic. Scar revision surgery is very variable depending on the type of scar that we are dealing with. If it is simply a raised pink scar after surgery, which can happen in certain skin types, particularly very fair skin types and very fair hair types, treatment may not actually involve surgery. It might be something non-surgical like steroid injection, laser treatment, or microneedling with an instrument such as the skin pen. If it is more extensive scarring, such as keloid scarring, which is scarring that grows beyond the normal limits of the scar and can be these sort of slightly bigger cauliflower type of scars, then it might involve a bit more than just steroid injection. It might involve actually cutting the scar out and then treating it with steroids afterwards. Then we've got scars that they may actually be very neat scars, but they've actually healed in a way that are pulling on things. So if there's a scar on the face that's perhaps pulling on the corner of the eye or the mouth, then we need to somehow lengthen that scar. And that's where some of the tricks of plastic surgery come in, which involve scar lengthening techniques such as Z-plasties or S-plasties, or reorientating scars so that they fit in with the normal facial creases. And these are very, very variable depending on what's needed and where the scar is and how it was caused. If it was a scar caused by an accident, then those can be quite tricky to fix because trauma doesn't treat your body in the same way that a careful surgeon would do. If it's after surgery, then the scars tend to be much more simpler in terms of where they sit and where they can be hidden. But generally speaking, a good plastic surgeon who knows how to release scars, excise scars, treat them with other modalities other than just surgery, a good surgeon will be able to find the best way to try and improve the appearance of the scar that's really bothering you. Coronavirus and plastic surgery, aesthetic surgery has been a really interesting combination. I mean, first of all, we had to deal with things in terms of what's the safest way of doing things. How can we make sure that we are doing things in the best way that is right for not only our patients, but the country as a whole, the population as a whole.
Sorry, start again, just the chairman.
Okay, sorry, a little.
Love the
Yeah. So, coronavirus and plastic surgery, aesthetic surgery has been a really interesting combination. We started off earlier this year with lockdown making us reevaluate what was safe, what's important, what should we be doing, what should we not be doing, and it took us a while to work out how we can safely continue to perform cosmetic surgery with the background of the pandemic looming over us. And I think we've done that really well. I think we have put in all of the safety measures that you can think of, all of the social distancing measures that you can think of. And actually, I think our record over the last few months shows that we're doing it really well. In addition to that, I think we've done it responsibly because everyone has been asked to step up to the mark and make sure that we're protecting each other as a population. We are protecting the NHS and therefore stopping it from being overwhelmed. So I can categorically say that us at Cadogan Clinic have not added to the problem of coronavirus for anyone else out there. When it comes to having surgery with the coronavirus pandemic at the stage that it is in at the moment, it's interesting as well as difficult to work out. And we are doing this in a way almost on a day-to-day basis, listening to advice from the government so that we can offer you surgery in a way that is safe without risking either you or those around you. It comes down to two things. If you have surgery and let's say you were to develop coronavirus, are you going to be okay? And in the main, I would say that our track record says that yes, you are, but we don't know that for sure. And we're doing our very best to try and mitigate that risk and minimize it as best as we can. If you have surgery and if you get coronavirus and you get problems following on from your surgery, do you get worse problems? And it looks like you probably don't. Again, our experience post-lockdown seems to suggest that actually in young, fit, healthy patients who are selected properly, screened and tested properly, and managed properly and efficiently, which is what we do here, it shouldn't make a difference. You isolate before surgery, you isolate after surgery, and therefore you should recover from your surgery perfectly well. Having said that, we are living in unknown times, and therefore there is a certain risk that we're all taking on in terms of the unknown. Time will tell, but the good thing is we are listening to the advice that we're getting. We are looking at all the data that is being produced, and we're taking it all on board, and we are applying that to our model here at Cadogan and just continuing to do things as safely as possible. And if there was ever any doubt about your safety, then we would not be operating on you. My name's Naveen Cavale. I'm a consultant plastic surgeon who works here at the Cadogan Clinic. I'm also the director of surgery here at the clinic as of late. And I come from a background of having been trained as a proper plastic surgeon, a fully trained, fully accredited, specialist registered plastic surgeon with the FRCS Plast qualification. I work in the NHS as well as in the private sector. I undertake reconstructive surgery in the NHS. I undertake aesthetic surgery in the private sector. I'm a member of all of the proper societies that you really ought to be a member of if you're going to call yourself a proper surgeon. And having been a consultant in the NHS for 11 years now and been a clinical director until very recently, looking after a very large surgical department in a very big teaching hospital, I hope I can bring sort of my experience and qualifications to a place like Cadogan, which has always had a reputation and a pedigree for selecting the best people to work here and offer the best surgery, which is quite right. That's what you should be getting when you come and seek out an aesthetic procedure.
I've done a few operations covering the whole spectrum, but if you want to talk numbers, I've done more breast surgery and rhinoplasties. This is like when I've done the most. I probably would say I've done over 6,000-7,000 breast operations and over 3,000 rhinoplasties, which are quite big numbers. I like doing them. You get better, I guess, with experience. So this kind of volumes are difficult to find. I remember when I was doing my training, and we're talking about surgeons that were operating and people that have done a lot. And I remember my boss at the time was saying 300 operations, 300 rhinoplasties is a really big number. But when I started operating, and I was doing a fellowship with a friend of mine, a colleague of mine who's a friend also, and he was telling me that, don't worry, the first 500 operations are the difficult ones. And at the time I was shocked. I'm like, I will never do 500 operations, but you do, and it's true. Because the first 100 operations you figure out the basics, how the nose works, but you really need over a few hundred operations to get confident that you can recover from any problems. So it is true, and it's difficult to find people that have done over that number, but yeah, I mean, I have done. Breast lift is an operation that lifts your breast, as the word says. There are a few different types of lift according to incisions, and also we have a lift with simultaneous augmentation, which you make your breast bigger, or just a lift where you just use your breast tissue. The lift addresses the droopiness of the breast, and that is it. There is this misconception that when you have a droopy breast, putting an implant in will lift it, and that is true to a very small degree. But essentially, people think that because usually what happens is that people lose weight and the breast is taut, but when they lose weight, the breast drops, and they think that by putting the weight on or putting an implant in the breast to give it more volume, it will lift it, but it's not how it works. So essentially, when you have a droopy breast, you need a lift. There are many different types of lift. There are many different techniques. Essentially, we're talking about two things when we do a lift, without an implant always. Removing excess skin, number one, and number two, mobilizing the breast tissue and adjusting the breast tissue to actually lift the breast tissue by itself. And then you secure it in a higher position, and that is the operation. There's many different ways of doing it, with mesh, without mesh, and the results are pretty good. People are happy if they know exactly what they're getting. The difference between lift with implants or without implants is essentially the upper pole fullness of the breast. A lift without implants doesn't give you a lot of fullness in the upper pole. If somebody wants fullness in the upper pole, then we will discuss implants. For a lot of people, they don't want this, they don't need it. In any case, having fullness in the upper pole is not really what nature intended. So yeah, that is essentially the difference. But putting an implant in means that on one hand that you have upper pole fullness, but on the other hand you have the implant-related complications. Okay, so it's one against the other. So it's not something for nothing. The surgical time for a lift is roughly between an hour and a half, and the surgical time for a lift with implants is similar, maybe 10-15 minutes longer. So it doesn't take. It's not too different really. So both operations can be done as a day case. The recovery is slightly different. When we're talking about a lift without implants, the recovery is pretty quick. There is virtually no pain because there is no implants. And people can be back to work within a week, back to the gym within a month, and back to normal within 2 months. When people have implants, I personally put most of the implants under the muscle, which is the bit that hurts. If it hurts. So the recovery can be a little bit longer, so people can go back to work after a week. But when it comes to exercise, I advise people to, after a month they can do lower body exercise or cardiovascular, and after 2 months they can do upper body, because the implants are under the muscle and they can be displaced if somebody starts exercising early. But it's the similar operations, not exactly the same, the similar. People come for a lift if they've got ptosis. That's the medical term. People that means droopy breast essentially in English. Now, why would somebody have a droopy breast? That could be genetic. It could be most often after weight loss or after pregnancy and breastfeeding. These are the most common reasons for people coming for a breast lift. So essentially it's a safe operation. Not many things can go wrong or do go wrong. And likely the things that are going on wrong most often are the simple ones. The most common problem is a little bit of slow healing in the wound, which is easily treated. Maybe you can have a small infection, maybe the patient can get a hematoma, which is a collection of blood in the breast, which can be treated by either leaving it if it's not a big one, or sometimes draining it. Scarring can be a problem, and that can't really be predicted, because scarring essentially depends on the patient's skin. And these are the main complications that are specific to the lift. General complications would be maybe a deep vein thrombosis or a blood clot, which is extremely unlikely, but I guess that's something that can happen with every surgery. These operations can be done as a day surgery and should be done as a day surgery if there is not a lot of travel between the patient's home and the hospital. I don't see why somebody needs to spend the night in the hospital, really, unless they're coming from really far away. There's not essential benefit. The painkillers that we need to give to the patient, they can take them at home. We don't need to keep them in the hospital. And I guess in the hospital, the longer you spend in the hospital, there are hospital bugs as well, hospital-acquired infections, which you don't. And I know that we're in a private hospital and we keep it clean and we screen everybody, but still, we don't really want to spend more time in the hospital than it's absolutely necessary. A chin implant is one of the operations that people don't think a lot about. Even though some people need it, shall we say. So my experience is that usually people come and I discuss about the chin implant when they come for a rhinoplasty, and they find out that the profile view is imbalanced, and most people think it's the nose that is the problem. But actually, if you look closely, you will find that the nose is half the problem, and most of the times the chin is too far back, it's hypoplastic. So that creates this imbalance. Chin implant is a very easy operation. It doesn't take too long. It takes maybe 20 minutes, 30 minutes. We make usually a little cut under the chin, less than an inch. There is another option to go in intraorally inside the mouth, but that is associated with a larger degree of complications. So I personally don't do that too much of that. And then you make a space for the implant just on the bone, and you insert a chin implant. A chin implant is made of silicone, solid silicone. We have 2 or 3 different types according to the shape that you want to get, and the projection and the dimensions and the dimensions of the chin of the patient. And you insert it, you secure it in the midline, and that's it. There are 3 main risks associated with a chin implant. Number 1, infection. Number 2, displacement. And number 3, nerve damage. Infection means that the implant gets infected and your body may want to get rid of it. Displacement means that the implant, you put it where you put it and it moves a little bit. And sometimes it's visible, sometimes it's not. In which case you need to correct it if it is. And then nerve damage means you have a nerve which is called the submental nerve. It's the nerve that the dentist numbs to give you a feeling. But this is quite close where the chin implant goes. And there is a small chance that it can either be squashed by the implant or even divided during the dissection for the chin implant. All of these are quite rare, 0.5% for each of those things. So in total you have 1.5% chances of something going wrong. But it's a good operation because it really does make a difference in the balance of the face. Gynecomastia surgery is for the reduction of male chest moobs, otherwise known. How common is gynecomastia? It's extremely common. About a third of men have it. We have 2 types of gynecomastia. The physiological gynecomastia, which is when for hormonal reasons you develop a breast tissue around the time of puberty, or you have the acquired gynecomastia, which is the gynecomastia development of breast tissue that you can get at any point in your life, and that could be because of illness, like hyperthyroidism, for example, causes you gynecomastia, drugs, steroids, medications for long term. You can have many reasons for gynecomastia. As I said, it's extremely common. About a third of men have it. The treatment of it is surgical. People have tried tamoxifen. Usually people that take steroids try to take tamoxifen to undo the gynecomastia, but it doesn't usually work. And the treatment of gynecomastia is essentially the removal of the breast tissue with the fat that's around it. So it's a combined operation that combines liposuction and direct excision of breast tissue. A lot of people are trying to perform it by just doing Vaser surgery. But my experience, and if you want to be correct, you need to say that Vaser doesn't really deal with the breast tissue itself. It's not strong enough to break down the breast tissue and remove it. So yes, it works in giving a better contour, but if you want to actually treat the gynecomastia, you need gynecomastia surgery, which could be in combination with Vaser or liposuction, but you actually need the breast tissue removed. The operation itself takes about 45 minutes to an hour. It can be done as a day case. Recovery is fairly straightforward. It's one of the few operations where we advise patients to start exercising early, after about 3 weeks. So somebody can go back to work after 1 week, exercise after 3 weeks, and they need to wear a garment which is quite tight for about a month. So there is a bit of swelling, a bit of bruising, some discomfort, but overall it's a very good surgery with minimal complications as well. So when would somebody come for a replacement of implants? There are 2 main reasons. Either because they have to, if there is a problem with the implant, or because they want to, and that's got to do more with the size of the implant. Sizing is self-explanatory. You want to go bigger, you want to go smaller, so obviously you just need to change the implant. Slightly more complicated is the reasoning if there is a a problem with the implant, and that can be a few different things. For example, you could have rippling, where the implant is in front of the muscle and it needs better cover, in which case we need to put the implant under the muscle. You may have a rupture, in which case the implant just needs to be removed. You may have encapsulation, which is when your body creates scar tissue around the implant, so we need to deal with that. So common, the common denominator in all of these operations is the change of implants, but simultaneously to that we may need to do other things. For example, release the scar tissue, the capsule as you call it, or remove the scar tissue if you have severe cases of encapsulation, or if you have a severe rupture with the capsule kind of being infiltrated by silicone, so you need to remove that as well. In my hands, when somebody wants to have implants taken from in front of the muscle and put under the muscle, then I tend to do a lift, pretty much in everybody that has this operation. So there can be many different reasons why you want to do this. It can be removal, replacement of implants. And removal of implants can be sometimes extremely straightforward, but sometimes quite complicated, depending on what is the problem and what is the reason. For the easiest kind of replacements is when somebody has got no problem and just want to change the size. In which case we remove the implant, do whatever we need to do to the scar tissue, maybe expand the pocket or reduce it, and put a new implant back in. So that doesn't take too long. That's easily a day case operation with minimal downtime. Things change if there is a pathology, so if we have to remove the scar tissue or put implants under the muscle, but still all of these operations can be done as a day case. In most of these operations there is no drains required, and in most of these operations, or pretty much all of these operations, you can go back to work after 1 week and back to exercise within a month or 2 months, depending on exactly what we need to do. So we start with the basics. People come and talk about facial rejuvenation. People need to know that the face is 3 parts. Is the brow, which is the upper part, the mid face, which is the middle part, and the lower face and neck. So the lower face and neck is what is treated with what people commonly call a facelift. That usually deals with this area. The mid face is a separate procedure that is what you call a mid-face lift, and then we'll go to the brow lift, which is an operation on its own. Now, the brow lift is probably the cleverest operation of them all, because you can do it endoscopically with a camera, with very small incisions that are all in the hairline. So you usually can do between 3 and 5 incisions in the hairline, and then you go under the periosteum, which is a layer just on top of your bone, release all the ligaments that hold the brow where it is, and with some anchors you pull it up. The main key to get a successful brow lift is not to overdo it, because you can get a permanently surprised look, which is not a good look. Obviously, you need to achieve symmetry. One reason for people having a brow lift, apart from the actual brow ptosis, which is what you get with aging, is asymmetry. So people come with different levels of brows. But by far and away, is the main reason is having low eyebrows on a woman. On the outer rim of the orbital rim, the brow should actually be about 1.5 centimeters higher. This is roughly the aesthetically pleasing position of the brow. The operation is clever, as I said. It takes about 45 minutes to an hour to do. Can be done as a day case or overnight stay. The main thing you need to know is that it is associated with a lot of bruising. So although it's a short operation, the recovery, it doesn't really hurt, but the recovery is quite long, maybe I would say 2 weeks, simply because people can be black and blue after it for a while and quite swollen. But it's a very good operation. And then also people come because they think they got excess skin in the upper eye, so they actually come forward requesting an upper eyelid surgery, blepharoplasty. But essentially the main problem is low brows. So if you actually lift the brows, then the skin lifts. So you don't really need upper eyelid surgery, you need brow lift. It's always about choosing the right operation. So generally speaking, and that applies to every kind of operation in surgery, not just in plastic surgery, is that there is a right operation for each patient. There is no such thing as one operation that fits them all. So a surgeon needs to know a few different ways of going about each particular problem and then tailor it to the individual patient. An advantage of having an experienced surgeon is that they can offer you the whole range of treatment and the treatment that is correct for you rather than the treatment that they actually do. For example, if you need a facelift but you go to a surgeon that doesn't do facelifts, they're not going to offer you a facelift, they will offer you fillers. And that is how you end up with bad results. The best thing about the Cadogan Clinic is by far and away the staff. The staff are just excellent, and the feedback that I get from patients is that everybody's nice, everybody knows what they're doing, they're experienced, and they make everybody feel at ease. Obviously, people can be stressed sometimes when they have surgery, but it is extremely helpful when the staff are knowledgeable and kind. It's a place where you see a lot of colleagues of different specialties working together, so you can exchange views, you can ask opinions. It's really, really good. We do a lot of different things here, a lot of different treatments.
Good afternoon, I'm Elaine Singer. I'm a nurse employed at the Cadogan Clinic. I've been working here for the past year. I'm Elaine Singer, I'm an ambulatory nurse at Cadogan Clinic. I've been employed with them for the past year. Hi, I'm Elaine Singer, I'm an ambulatory nurse at the Cadogan Clinic. I've been working here for a year. Well, in the clinic we look after patients who are recovering from surgery. They're usually day case patients. They come to us and they're with us for about 2 to 4 hours maximum while they help to recover post their surgery. We monitor their observations and make sure that they're absolutely okay before we send them home. An ambulatory nurse is usually an experienced nurse who cares for post-operative patients when they've had day case surgery. They come to us straight from recovery. We monitor their observations and their dressings and their drains, make sure they're absolutely A-OK before they're sent home to recover. An ambulatory nurse is someone who looks after patients who come to us from theatre to recover. We take their observations and check their dressings, make sure that they're clinically stable before they're sent home to recover. Well, the things that we look for in patients before we send them home is that their colour is good, their pallor is good, they're pink, they're obviously ambulant, they're actually making sense and talking to us, they're happy, their observations are perfectly stable, their dressings are perfect, there's no ooze, they've eaten, they've drunk and they've been to the toilet. And they're actually very comfortable and coherent, the same as when they first walked in, before we would send them home. Depending on the type of surgery that they've had, the minimum time a patient would have to stay with us post-surgery would be 2 hours. That would give us time to make sure that they're coherent, their vitals are stable, and they've eaten and drunk, and that we're really happy with them. And most importantly, they have someone to take them home and to monitor them and to care for them once they get home. Depending on the type of surgery the patient has had, it would usually take between 2 to 4 hours before we would allow them to go home. It would depend on their vital signs, whether they've had something to eat and drink, and they need somebody to take them home. But it would depend on the type of surgery and how extensive it had been. Depending on the type of surgery that the patient has had would depend on the amount of time they would be with us before we sent them home. Someone who's had a labiaplasty or blepharoplasty would probably be with us post-operatively for 1 hour once they were out of recovery. But someone who's had an abdominoplasty would potentially be with us from 2 to 4 hours, depending on their recovery time. They may need more time for their observations to settle, for the pain to be relieved and in control, and it may take them a bit more time to mobilise and to eat something and be to the toilet before we would be happy to send them home. So depending on the type of surgery, it may take them a little bit longer to go home. We would insist that a member of the family or friend would take a patient home because they've had a general anaesthetic, and people, they may think that they're okay to be on their own, but actually they're not. They might tumble, they might slip. If they've had a general anaesthetic, they're not really, they wouldn't be happy. I wouldn't be happy. I can't think of what words I want to say.
Yeah.
We insist on patients going home due to their safety. Somebody needs to look after them and make sure that they're in a safe environment. It's important for people to have a chaperone to take them home, to make sure that they're safe, and just to make sure that they don't fall over and they're in a safe environment. It's important for a patient to have a chaperone home for their safety, and because they've had a general anaesthetic and they may fall or they may succumb to some harm, so we have to ensure that they're safe. Depending on the type of surgery the patient has had, usually we'll see them a week post-operatively, but if they have any problems, they can always ring us and come in and see us before that. And I would insist that they do so. We check with them 24 hours post-op and phone them to make sure that everything is okay. And if it usually is, but if it isn't, they would come in to see us, and I would just book them in an appointment to check to make sure that they are okay. At their 1 week post-op appointment, we would check their dressings and their wounds. We would follow the post-operative instructions from the consultant. Sometimes they just need to have their dressings reduced. Sometimes they may need to have their sutures removed. It just depends on what the procedure has been. We would usually check the patients the 2nd week post-operatively. I would usually get them back to check to make sure they're happy with everything. Everything has wound properly. They may need to have sutures removed depending on the type of surgery they've had. Sometimes sutures need to stay in 10 to 14 days post-operatively. And we would check that they're healing well, they haven't got any temperatures, they haven't got any problems, they're actually coping with the surgery that they've had done. Some patients do find it hard once they've had the surgery. It's a psychological impact that it has on them. They can find it very overwhelming and they just need that emotional support. And that comes across quite a lot actually post-surgery for some of these patients. So you just need to spend a bit of time with them. At the 2 week post-op check, we would sometimes take their sutures out. Occasionally patients need to have sutures out between 10 and 14 days. If a patient has a problem or concern with their treatment, they need to call us. They can do that by emailing us, they can ring us in the clinic, or we have a 24/7 on-call phone. They can ring us and speak to one of the nurses, and we can help them sort their problem out if they have a problem. We can get in touch with the consultant by email, or we can ring them, and we can get back to them immediately and help them sort their problem out. If it is a big problem, such as they've got major swelling, excessive bleeding, then they must speak to us, but then we would advise them to go to the local A&E. If a patient has a problem post-surgery, they can call us on our 24/7 on-call landline. The nurse also has an emergency phone. They can ring us at any time. They can also contact the consultant. They have written information given to them to take home. They can also contact the clinic and ring the clinic, and the receptionist there can try and get in touch with us. But if they have a major problem with swelling or any sort of hemorrhage, then it's always best to go straight to A&E. Sorry, go on.
No.
If a patient has a problem the following day post-surgery and the clinic is closed, they can ring us on our 24/7 on-call phone, where a nurse will speak to them and help them to sort their problem out, because we can contact the consultant and we can advise them. If a patient has a problem, say a couple of days or a week post-surgery, they can ring the clinic, get in touch with us. The people in the clinic can speak to the nurses, and we can get them to come in and see us. And they can also email us, send us pictures of the problem, and we can speak to them. At any time, you can get in touch with the nurses at the clinic, but out of hours, you can also ring the online number, which is 24/7, and the nurse will answer that and help you. I think if you're nervous before surgery, you should speak to the consultant with your concerns, because it could be something that you just haven't understood fully and they need to go over again. But other than that, you can speak to one of the nurses at any time at the clinic, or you can also call the on-call phone and speak to them and just say that you're worried and you're concerned and you'd like to talk it through. And anyone will be happy at any time to talk it through with you. You need to stop smoking pre- and post-operatively because it helps with the healing process. If you smoke, it will deoxygenate the blood, which is needed to help with the healing process, and also it will help you to stop getting infections post-operatively. You need to stop smoking pre- and post-operatively to prevent problems such as DVTs occurring, and also you need to be able to heal properly. Smoking decreases the oxygen levels in the blood, which doesn't help with the healing process, and also it will give you risk of infection. You need to stop smoking prior to surgery because it helps with the healing process, and also it prevents complications such as DVTs post-surgery. If you feel nauseous after your anaesthesia, we can give you antiemetics to stop the nausea. It's very uncommon now to feel nauseous after surgery, but if you do, we can give you things to prevent that. And also the anaesthetics are very, very light now. You don't have the complications that they used to have many, many years ago. It's very uncommon now to feel nauseous after surgery, but if you do, we can give you antiemetics to stop you from feeling nauseous. And you shouldn't have many problems at all. It's very uncommon to feel nauseous after surgery now, and if you do, we can give you anti-sickness medication to prevent that so that you feel so much better, and it makes your recovery much quicker. The nausea usually comes from anaesthesia. Some people, it's very rare, are sensitive to certain drugs, but it's extremely rare. But if you do feel nauseous, we can give you anti-sickness drugs to help you feel much better.
Perfect. Yeah, that's nice.
Which is true, actually.
Yeah, that's great. Fantastic.
Will I need to wear a garment after surgery?
Depending on the type of surgery you've had, you may need to wear a garment for 1 week to 6 weeks post-surgery, but it depends on the surgery that you've had.
Okay, should we add to that?
What types of surgery?
Obviously, your surgeon will recommend exactly what you need, and is it provided as well?
Yeah.
Yeah, and it will all be provided for you, something like
Sure, yeah. Depending on the type of surgery you've had, you may need to wear a garment post-surgery. This will be provided for you at the clinic, and you will be given instructions from your consultant how long you need to wear the garment for. You will be advised by your surgeon as to when you can what's the word I want? Resume. I was going to put review, and I was just thinking that's so not the right word. You will be advised by your...
Leave a little bit more of a pause at the beginning, looking forward.
You will be advised by your consultant when you can resume your normal exercise and routines. This will depend on the type of surgery that you've had. Depending on the type of surgery you've had, you'll be advised by your surgeon when you can resume your normal activities. This will depend on the type of surgery that you've had. The benefits of day case surgery are that you can go home as quickly as possible and you have a better recovery rate at home. Also, there's less chance of acquiring an infection and less chances of possibilities such as DVTs and post-operative problems. The benefits of day case surgery are that you can go home much quicker, which means your convalescence is much quicker also, and there are less problems with infection and problems with DVT. The benefits of day care surgery is that you go home much quicker and your recovery time is much quicker. There are less problems with DVTs and also with infection. Day case surgery is better for the patient because they get to convalesce much quicker and the infection rate is lower. There are less problems with DVTs and less problems with contracting an infection. The fact that they can convalesce in their own home, it keeps their blood pressure down, which helps them to heal much quicker. It's much nicer being in their own environment and being cared for at home. The less chance of getting an infection, and also less problems with acquiring a DVT, which can be fatal.
Hi, my name's Ellie. I'm a healthcare assistant at the Cadogan Clinic. Hi, my name's Ellie. I'm a healthcare assistant at the Cadogan Clinic. Yes, you can have a chaperone if you request it at reception or with your doctor. A chaperone is available for every appointment. You can request this at reception or with your doctor. A chaperone is available for every appointment. You can request this with reception or with your doctor. You can have a chaperone in your appointment so that you feel completely comfortable during an examination. You may want a chaperone during your appointment so that you feel comfortable during an examination. On the day of your surgery, you should bring some comfortable clothing that is open at the front. On the day of your surgery, you should wear loose clothing, open at the front, something comfortable. On the day of your surgery, you should bring with you toiletries and any everyday medication. On the day of your surgery, you should wear loose clothing, something comfortable that opens at the front. On the day of your surgery, you should wear loose clothing that's comfortable and opens out at the front. You'll be provided with a gown, socks and slippers. On the day of your surgery, you should bring with you any everyday medication that you take and any entertainment for afterwards after your surgery. You should bring with you any everyday medication that you take and something to pass the time after your surgery. You should bring with you any everyday medication that you take and maybe a Kindle, an iPad and some headphones for after the surgery. You should bring with you any everyday medication that you usually take and something to pass the time after the surgery, such as a Kindle, an iPad or some headphones. You shouldn't eat anything 6 hours prior to your surgery. You should not smoke a week before or after your surgery. You shouldn't eat anything 6 hours prior to your surgery, but you can stay hydrated. We recommend not to smoke 1 week before your surgery day. We recommend that you stop smoking 2 weeks before your surgery, as this helps with healing. We recommend that you remove all makeup from your body and you don't have any gel nails. We recommend that you wear no makeup on the day of your surgery, that you shower beforehand, and that you don't wear any nail varnish, gel nails or nail polish. We recommend that you do not wear any makeup on the day of your surgery, as this could interfere with your treatment.
Hi, I'm Jennifer. I'm one of the receptionists here at the Cadogan Clinic and I welcome every patient on arrival. We screen every patient before they arrive with a series of questions, and then once you arrive we'll take your temperature, we'll give you a mask, sanitize your hands. So we screen every patient when you make your appointment before you arrive with a series of questions, and then once you arrive we'll take your temperature, we'll give you a mask if you need one, and then you can take a seat in our socially distanced waiting area. So a member of our staff will greet you, we'll check and confirm all of your details, and you may spend a little bit of time in our waiting area, but then a nurse will soon greet you and take you to a private preoperative room. On the day of your surgery, one of our members of staff will greet you, we'll check and confirm all of your personal details. You may spend a little bit of time in our waiting area, but then a nurse will come up and greet you and take you to your private preoperative room. So everyone here is super welcoming, everyone here was really lovely and helpful with everything that I needed. I didn't feel afraid to ask any questions, everyone was super supportive of me learning and joining sort of a medical environment. Patient care is absolutely at the forefront of the company, everything is patient first. The Cadogan Clinic is absolutely patient first, it's first class care and it's really high quality safety precautions, and we've got leading consultants here. My favourite thing about the clinic is definitely the staff. Everyone is super lovely, everyone as well puts the patient first. It's a very welcoming environment, it's very clean. I know it's a funny thing to say, but it's super, everything is taken care of down to every last detail. It's very detail oriented. If you have any questions that happen out of hours or you think is urgent, you can give us a call on a 24-hour... If you have any questions that are out of hours or you think that's urgent, you can give us a call on our on-call nurses number that's 24 hours, and they'll be happy to help you, and you'll be given this number on the day of your surgery.